Hello and welcome. Today, we're taking an in-depth journey through some of the most critical areas of pharmacology. We will explore the drugs that create and control our blood, the powerful agents that manage cholesterol and blood pressure, and the medications that help us breathe. This is your comprehensive guide to mastering these essential topics. Part 1. Drugs for anemia, the hematinics. Let's begin with the very foundation of our blood, the process of hematopoiesis, the formation of all blood cells from stem cells in the bone marrow. When this process falters, specifically in the production of red blood cells, anemia can result. The drugs we use to combat this are called hematinics. The cornerstone of red blood cell production is iron, a vital component of hemoglobin. Iron deficiency leads to a hypochromic, microcytic anemia. Treatment involves oral iron supplements like ferrous sulfate or ferrous gluconate. Remember, for iron to be absorbed from the gut, it must be in its ferrous, Fe2+ state. Another major cause of anemia is a deficiency in vitamin B12 cyanocobalamin or folic acid. Both are essential for the synthesis of DNA, and their deficiency leads to a megaloblastic, macrocytic anemia. Finally, we can directly stimulate red blood cell production using erythropoiesis-stimulating agents, or ESAs. These are recombinant forms of erythropoietin EPO, the hormone naturally produced by the kidneys that drives erythropoiesis. Drugs like epidin alpha are crucial in treating the anemia of chronic renal failure and anemia induced by cancer chemotherapy. Part 2. Coagulation and thrombosis, a delicate balance. Hemostasis is the process of stopping bleeding, while thrombosis is the pathological formation of clots. The drugs that influence this balance are among the most important in medicine. To prevent clots from forming, we use anticoagulants. Heparin is a fast-acting, parenteral anticoagulant that works by activating antithrombin 3, which in turn inhibits thrombin and factor XA. For long-term oral therapy, Warfarin has been the standard. It works by inhibiting the synthesis of vitamin K-dependent clotting factors 2, 7, 9, and X. Its effect must be closely monitored using the inner. More recently, direct oral anticoagulants DOACs have become widely used. These include direct thrombin inhibitors like dabigatran and factor XA inhibitors like rivaroxaban and apixaban. To prevent arterial thrombosis, which is primarily driven by platelets, we use antiplatelet agents. Aspirin is the classic, working by irreversibly inhibiting the COX-1 enzyme, which blocks the production of thromboxane A2, a potent platelet aggregator. P2Y12 inhibitors such as clopidogrel block ADP-mediated platelet activation and are often used with aspirin in dual antiplatelet therapy. When a clot has already formed and is causing an emergency like a myocardial infarction or ischemic stroke, we use fibrinolytics or thrombolytics. These are clot busters like alteplase and streptokinase that work by dissolving the fibrin mesh of existing clots. Conversely, to promote clotting and stop bleeding, we can use antifibrinolytics like tranexamic acid, which inhibit the breakdown of fibrin. In cases of warfarin overdose or vitamin K deficiency, we administer vitamin K itself. Part 3. Antihyperlipidemics. Controlling cholesterol. High levels of LDL cholesterol are a primary driver of atherosclerosis. The most effective drugs for lowering LDL are the statins. Their mechanism is brilliant. They inhibit HUM-co-reductase, the rate-limiting enzyme in cholesterol synthesis within the liver. This reduction in intracellular cholesterol causes the liver cell to upregulate its surface LDL receptors. These receptors then pull more LDL cholesterol out of the bloodstream, lowering serum levels. The most significant adverse effects to monitor are myopathy, muscle pain and damage, and potential hepatotoxicity. A newer, highly potent class of drugs is the PCSK9 inhibitors, like alirocumab and evolocumab. PCSK9 is a natural enzyme that binds to and degrades LDL receptors. By using monoclonal antibodies to inhibit this enzyme, these drugs dramatically increase the number of available LDL receptors, leading to a profound reduction in blood LDL levels. Other important lipid-lowering classes include the fibrates, which are the most effective drugs for lowering triglycerides, ezetimibe, which inhibits the absorption of cholesterol from the intestine, and nicotinic acid, which is the most potent agent for raising HDL, or good cholesterol. Part 4. The RAAS System and Diuretics. Managing pressure and volume. The renin-angiotensin-aldosterone system. RAAS is the body's master regulator of blood pressure. When the kidneys sense low blood pressure, they release renin. Renin converts angiotensinogen into angiotensin I. Angiotensin I is then converted by angiotensin-converting enzyme ACE into the highly active angiotensin II. Angiotensin II is a powerful vasoconstrictor and also stimulates the adrenal gland to release aldosterone, which causes the kidneys to retain sodium and water, thus increasing blood volume and pressure. We can inhibit this system at several points. ACE inhibitors, like lisinopril, block the conversion of angiotensin I to II. Their hallmark side effect is a persistent dry cough. Angiotensin receptor blockers, or ARBs, like losartan, block the receptor for angiotensin II directly, achieving similar effects without the cough. Diuretics are drugs that promote the net loss of sodium and water in the urine. Loop diuretics, like furosemide, are the most potent. They work in the thick ascending limb of the loop of Henle to inhibit the Na plus K plus 2Cl cotransporter. They are used for significant fluid overload. Thiazide diuretics are less potent and work in the distal convoluted tubule. They are a first-line treatment for hypertension. Finally, potassium-sparing diuretics like spironolactone are often used in combination with other diuretics to prevent potassium loss. Part 5. Respiratory drugs, the air we breathe. For cough, drugs are divided into two main categories. Expectorants, such as guaifenesin, increase bronchial secretions or reduce their viscosity to make a cough more productive. Antitussives, like codeine and dextromethorphan, suppress the cough reflex in the central nervous system and are used only for dry, non-productive coughs. Asthma management revolves around two strategies: relievers and controllers. Relievers are for acute attacks. The most effective are the short-acting beta-2 agonists SABAs like salbutamol, which provide rapid bronchodilation by relaxing airway smooth muscle. Controllers are used for long-term prevention. The absolute cornerstone of asthma therapy is inhaled corticosteroids, like fluticasone. They don't provide immediate relief, but they powerfully inhibit the underlying airway inflammation. For more severe asthma, they are often combined with long-acting beta-2 agonist LABAs like salmeterol. Other controllers include leukotriene modifiers like montelukast, and for severe allergic asthma, the anti-IgE monoclonal antibody, omalizumab. Conclusion: from manipulating the complex cascade of coagulation to fine-tuning blood pressure with pinpoint precision, and from clearing our arteries of cholesterol to opening our airways, pharmacology is a science of profound intervention. Mastering these drug classes, their mechanisms, and their side effects is not just an academic exercise, it is the fundamental skill that allows us to safely and effectively harness the power of medicine to heal. Thank you for watching.